Okay, I just want to note to everybody, I've started recording the meeting. Happy you could all make it. I have the sense that everybody on this call already knows each other. And I'm wondering how people feel about, rather than going around and everybody saying their name, because we can see your name. If you have some update that you'd like to give us, go ahead and just wave your hand and we'll let folks convey any updates they have, and then we'll jump into our agenda.
Yeah.
Looking.
Yeah, I'm just getting on it now. I really don't want to be. I'm so tired of being on the freaking phone today on Zoom.
And that's Jim Novelli, who is very excited about being at this meeting, I can tell.
I know that Joe Knoll has an update.
Say that again.
I know that Sheriff Knoll has an update I'd like to hear. Sorry, I'm volunteering you, Sheriff.
I'm not, yeah, I don't know. I'm not sure what that is.
Maybe.
Well, you're your new employee.
Oh. Do I have permission to talk about that?
Of course.
Yeah, we have our new navigator has started out here. He's been here a little over a week now, and is settling in, and we've had at least one call I know that he went to, and it involves a learning curve. So, but we're looking forward to all the good things he's going to be able to do. And I want to thank some people here that were, I know Greg was on the committee, and Patrick, and Jolene was asked for some advice on some stuff too when we went through the RFPs. So thank you for your time in doing that. But we yeah, and he's excited. So see what happens.
Lori, I came a little bit late, so I don't know what we're doing, but I could give a little update if that's what we're doing. This is Denise.
Yes, and I want you to know the first slide in my presentation is about your drug take back, so don't take away the thunder on that one.
Okay, I won't. All right. What I was just gonna share, a great job, everybody. I've been volunteering at the Recovery Cafe, and today we had, about 12 people for lunch, and had a super enjoyable time. And I talked to a woman who was really grateful to OLICAP and to the shelter at the fairgrounds that provided her tent and put a mattress in it, so she was on the ground, and feels very safe, and is doing really well. And so I don't know, I know that mostly what we hear is, oh, we aren't doing enough, or there's so many people slipping through the cracks, but these are two programs that are really helping a lot of people in our community. And so I feel really blessed to be able to help out in that way. So just wanted to give us some yay team.
Thanks for an update, and what a gorgeous day to be out there. Okay, unless there are other updates, I'm going to switch over to the presentation, share my screen really quickly. Okay, can you folks see the upcoming event that now Denise can talk about? The Drug Take Back Day. I just wanted to say Denise worked so hard on this every time it happens. And you can see that last year they got an incredible amount. And I wanted you, Denise, to give us a little update on what's going to be happening this month.
Well, this is a partnership between the Sheriff's Office. So Joe Knoll is just as active in this as I am, and QFC. And so QFC always provides a pharmacist at our table who can answer any questions anybody might have about, any kind of drug that they've been prescribed or they're thrown away or whatever. And we take any over-the-counter or prescribed medicines, no questions asked. You just throw them in the box at our table, and then we pack them up and we weigh them and we send them back, and the DEA incinerates them. So it's a real clean and tidy way to get rid of excess medications that might be hanging out in your medicine cabinet and might get into the wrong hands. And so, because we know that one of the ways that young people get prescription drugs is by going to grandma and grandpa's house and just taking some out of the cabinet. That's a pretty common way to get them. So this is really a great service that we provide for the community. We do it twice a year, once in October, once in April. And we usually take back between the drug takebacks we have in Hadlock and the drug takebacks we have in Port Townsend proper. We usually take back, excess of 500 pounds of drugs each time. So anything else I should say about that, Lori?
No.
In the meantime, there's a kiosk at the Sheriff's Department always, and people can dispose of their unused medications there. And also there will be soon enough through Med Project kiosks in the QFC in Port Hadlock, and then likely in the QFC in Port Townsend once they get their pharmacy built in that store. So yeah, I guess that's it.
Oh, great.
I wanted to add to that if I could. Denise is far too humble. She does everything. And I show up with a scale to weigh the stuff and then haul everything off. But she does everything. And she also gets the opportunity. She gets to hear citizens say nice things to me and citizens rant on me. So she gets to experience some of that. But yeah, it's all her. So good job, Denise.
Right, Joe, but you got to field all the citizens. I don't have to do any of that.
It sounds like you guys are a good team. Okay, for today's meeting,
Lori.
Yes.
Hey, everybody, this is Lisa. I just want to say real quick, another really great thing about that is it keeps the drugs out of the wastewater and out of the ocean. Colleagues at the Institute where I am did a study a while ago, so thank you for that as well.
That's good to know. It impacts so many different areas.
And Lisa, just to that point, this morning at our staff meeting, a question came up about how we could kind of promote this through our septic solid waste folks at EH. And so I'm working with Linda Atkins to figure out a way to do some education around drug disposal for folks who have septic systems.
Okay.
I don't know if I should say this or not, but just to add a little history. When I was a new deputy, you would, if you had drugs to dispose of, you would get a witness, another deputy, and go in the bathroom and flush them down the toilet. So that's just the way you did stuff. So.
A little evolution since then.
Yeah, for sure. I witnessed that. That happened at my house. As a matter of fact, when my husband died, the sheriff was there with the deputy and they threw all of the drugs down the toilet. And I was like, I don't think you should be doing that.
We have some, we're specially trained, so we know how to do that.
Yeah, I can just use the example that I had of cleaning out my dad's place after he died. He had been getting prescriptions by mail for years and only took a fraction of them. And there were so many in that house. I mean, luckily I knew what to do with them, but I can definitely see some people coming into their parents' place after they pass and being overwhelmed by that. And I don't know if it would make sense to maybe have an additional kiosk out at the transfer station or not. I mean, I know there'd be kind of a concern with it, the security there maybe not being as tight as at the sheriff's office, but I can definitely see some people, not knowing what to do and just hauling them over to the dump.
That's a good idea.
Maybe medium hazardous waste that's once a week and has an attendant to make sure that they can they can process it would be a more appropriate place. So there's some management there.
Right.
It's a good idea.
Sorry to interrupt. There are some rules with DEA though on where drugs can be dropped off and stuff. And I think that has to be monitored by law enforcement or something. That's changing. And I don't know if it's still, the idea of being able to have them in the stores now that's a new thing. And anyway, it's a good idea though.
Well, we're going to track down what we can and cannot do and see where we might, because that's a really good idea, James, to make more locations available. I want to draw everybody's attention, first of all, to the fact that in the chat, Jumping Mouse is seeking an executive director and OLICAP COVID navigator. So there are links there in the chat to both of those job offerings. So go ahead and have a look there. Today, we're going to move quickly through a quarterly report update. Lisa Grundl from HFPD is going to give us an update on the behavioral health data that we've been collecting and what we're learning from that. Then we're going to have Melmud give us an overview of what OCH is doing on their plan to address stigma. They got a great grant here a little bit ago, and so she's going to give us an update on that. Then we're going to talk a little bit about the survey that you folks filled out and the responses and what we're going to do next on that front. So to begin with, on the deliverables for the HRSA grant, we had a PIMS report, a QPR report, and an updated work plan. And I'm happy to say we got all of them in, and not only did we get them all in, this was the first time we'd done the PIMS report, and you guys are my heroes. The service providers that went through their data and provided what was just incredibly detailed bits of data. We sliced their patient populations every which way you can imagine. I really appreciate that you guys got us that data. When I was going back and forth with Erin, our person in Washington, D.C., she said people with the large consortiums have the worst time with it. And she was really surprised we got everybody's data this first time in. So thank you, you guys. On our work plan, I can tell you that for all of the grant activities, there are all of these required activities within prevention, treatment, and recovery. We were able to do something on 90% of them. So I felt like we're doing well. And I also have a much clearer idea of some things that I really need to pay attention to here in the next 3 months. Let's see, then I thought I would pass it over to Lisa to talk about the data and the work that she's been doing with everything that you guys have handed in.
Hi, can you hear me? Yep, good. So yeah, thank you too for everyone that not only got Lori her data for the PIMS report, but also got all of us got the data that we needed to update the work we've been doing. So as you know, we've been asking you for quite some time for data, and we were excited this time to do a whole year's look at everybody's data just to see how things had changed. And you'll see on some of the next slides, we really tried to show month by month because it's very interesting when you look just like percent change over the year. It doesn't tell you nearly as much as when you look at each month. So some of the slides are pretty busy, but we think they're really valuable in what they show as far as the fluctuations that are happening in each of these different areas where you guys are gathering data. So we start with the Port Townsend Police Department, and we've said this before, the majority of the incidents that they report are mental health. And then there's also, they do a good job of just showing when there's more than one issue that they're dealing with. And so that's broke down, and you can see in this table that there's a wide fluctuation between drinking and drugs and mental health. If you go to the next one, Lori, you can see, but what we really wanted to show in this one is the trends over time, because the green line above is the mental health, exclusively mental health incidents. And you can see they've increased by about 13% during that period of time, but have wide fluctuations. And then the other ones, the other incidents that have mixed, either drugs, alcohol, or mixed with mental health, have stayed relatively flat, you can see the month by month is interesting because there are some spikes here and there, but overall from March to February of this year, March of last year to February this year, the mental health incidents that Port Townsend Police Department is dealing with are increased by about 13%. You can go to the next slide. And this just shows, we did these annual changes, and I know the numbers are really small, but I just thought it was interesting to look more at each column individually, because then you can really see not just the lines, but kind of the numbers that they're dealing with as they look at some of these categories. And so obviously mental health is the biggest category, but you can see that with these small numbers, the percent change is really doesn't show a lot, except to show that there are some places where things are decreasing and some are increasing over time. So we thought it was interesting to just kind of take a look at that. And then the next slide, and this is from Discovery Behavioral Health, and these are their ITA investigations. And again, if you only were looking at March to February, you wouldn't see that much change, but it's very interesting to look over time. 11% of their ITA investigations result in involuntary commitment, but this data shows the referrals for those that don't get involuntarily detained. And so there's quite a mix month to month what they're seeing, and we just thought that was interesting to look at. And Lori, if you go to the next slide, you can see again over time just the change in total ITA investigations. And again, the 41% of them are referred to outpatient mental health and 22% to inpatient mental health. And these are all, of course, of the voluntary, not detained referrals. I'm just gonna keep moving unless someone shouts out that they have a question, because I know we have a lot on the agenda. So this is ED data from Jefferson, and overall, their behavioral health incidents are down from March to February, but they, I'm sorry, that doesn't look quite right. It doesn't look quite right. They're actually, I think, up by 10%, but they've decreased in behavioral mental health and increased in SED. So again, you can see the month by month fluctuation. And when you take all the data over the year, about 80% of their incidents are mental health related. And the mental health is the blue. And 70%, we thought this was interesting. This came from the data that they did for PIMS, actually, when we were drilling down on some of the data that the HRSA specifically wanted. And about 70% of the ED and clinic patients that Jefferson Healthcare diagnosed with the SUD over the last 6 months were diagnosed with an opioid disorder. So I thought that was an interesting new data that we hadn't seen before. And this data here is from Jefferson County Jail data. And we did it this way because there's some duplication here. When we tried to put it together, some of the same patients that were booked on drug and alcohol charges also might have had MAD inductions. So we thought splitting it out, you kind of see the differences in the number of those issues identified. It's not number of people, because there's duplication there. And again, you can see a lot of fluctuation by month and some differences depending on which category you're looking at. So we thought that was a nice visual just to show the differences that they're facing on a daily basis and then monthly basis anyway. And then if you can go to the next slide, Lori. And this just, again, we thought it was kind of useful to see the actual numbers and see, you see mental health seems to be decreasing over time with a lot of fluctuation, whereas some of the other booked on drug and alcohol charges, that's increasing. So just differences across the board there. And then,
Lisa, could I ask a question?
Yeah. Can't tell who's that. Oh, yeah.
This is Greg. Hi. Can you go back 2 slides, Lori? Sorry to that. Yeah. Oh, back 1. Sorry. Yeah. So if looking at the number that were booked on drug and alcohol charges compared to the reported substance abuse problems, it looks like there's a lot of correlation. Like often people that are booked are dealing with that issue and receiving treatment. I guess I'm just wondering the decline, if it's just a systemic issue with the Blake decision, and if that means that there are going to be, I guess, what kind of permutations people I'm not sure if this is a question for you or the group, but what kind of permutations might come from that change now?
Well, that's a great question. And actually you'll see on our next step slides, we want to be talking about that at our, I don't know if it's the next meeting or the meeting after. We want to really drill down on some of this data and see, yeah, what's the implications of what's going to happen with that decision. So I think that's a good point. And later, you can see we have some data about the number of people that were assessed in the jail too. And so that's other good data to be considering when we're looking at those assessments and those referrals, like just what's the landscape going to look like with that decision. So
Lisa.
Hi,
this is the other Lisa.
Oh, hi, Lisa.
I got a chat. I think they thought I was you asking about the acronyms, which I went ahead and responded. But if you use an acronym, would you mind saying what it means?
Which acronym are you talking about? MAT, medically assisted treatment, medication assisted treatment? Is
I'm
that
not
the one?
Anytime.
Okay, yeah, I just wanted, if there's any other ones, shout out to me if I'm using acronyms that people don't know, please.
Thank you.
Yes, of course. So now where were we, Lori?
Maybe there or maybe here.
Yeah, here. I think we were just getting to the sheriff's county. So, and here's the data from the Jefferson County Sheriff, and 50% of their behavioral health calls are mental health related. And again, this one could have duplication, and we just don't know, because this is they look at this from the kind of top of the mind, what's the issue of the day, and so they split them out separately. But there could be obviously some co-occurring issues here, but we don't have that data broke down that way from the sheriff.
Lisa, this is Cherish from OLICAP. What I'm wondering is there data from last year, because I'm interested, obviously due to COVID, right? You know, there was, I think, a real lean towards trying to reduce the number of people that were being brought in and stuff. And so I'd be interested to see overall, you know, due to COVID, what percentage changes, you know, got booked into jail, and just overall, if there's last year's numbers somewhere I can look at.
So you guys are making John and Lori and I feel really good, because the two things that we decided we wanted to drill down on for the next time we talk about data are COVID and the decision. So
Right.
we do want to, we do want to really look at that and see how things have changed, and what impact there was and maybe continues to be from COVID. So those we wanted to drill down on that more and focus on that more when we have more time. So
great. Okay, thanks.
Cherish, this is John, and I'll talk about it a little bit more later. But when one of the things we want to do is for those data elements where we have data that goes back pre-COVID, kind of do a change chart that looks at you know, what's the delta between pre-COVID incidents and post-COVID incidents. And I think that'll be a really interesting thing for people in our community to know.
Definitely.
Great, thanks.
And then the next slide, Lori. So this data we didn't have by month. So what we did is we took the groupings that we did have and we just kind of averaged them to see what was happening with the different categories. And so you can see just from March to of 2020 to February 21, how they changed. Those are the average numbers during that time, each of those time periods. So you can see the decline there. And then this is East Jefferson Fire Rescue's data, and we 82% of their data is by is mental health, and you can see the much smaller numbers for alcohol, opioid, and unspecified other drug calls. Again, this is top of the mind data, so there could be some. I don't know if top of the mind is the right terminology, but it's the issue of the day, the main issue that they're dealing with. So again, there could be some co-occurring things that we aren't catching with that data. Next slide. And this is what I was talking about. These are the assessments that are happening in the jail. And so the majority of the assessments, 92%, result in recommendations for inpatient STD treatment. And 65% of the assessments, and again, duplication in here, it's not some of the same patients, but 65% of assessments also result in a referral to MAT and 55% to other mental health services. And importantly, I thought it was important to note when you look at some of these things, they also, the majority of these people need assistance with transportation and other social determinants of health, including housing, employment, and other things like that, which is not surprising, but important to keep.
Lisa, Adam had a question around if the calls for intentional overdosing are being categorized as drug or mental health / suicide attempts.
For which,
I think we're going back.
which slide?
Which slide was that, Adam?
I think that was probably the,
All of them. Oh, okay.
well, there's one that had the suicide. Go back a little bit further. Let's see. I guess my quick answer is that's a good question. Oh, here it is. This one, Jefferson County Jail intake data. Is this the one? No, that's not the one I was thinking of. So you're asking if they would categorize it as a mental health issue versus a drug issue if it was an intentional overdose? That's the question.
I think that's what he's asking.
Yeah, okay. That's a good question. And I don't know the answer to that. So when we should get some more information from and if anyone that gave this data on the phone can answer that quickly. That's a good question, because some of the people that provide data, some of these areas do tell us if it's co-occurring. For example, go back where we had they do the had been drinking and a mental health. They combine that data. Trying to find that. Let's see. I think it was the yeah, here where you can see that they tell you if it's been mental health or drugs, but then other people we said were top of the mind, so they would do the issue of the day. And so that's a great question for East Jefferson Fire Rescue. Is anybody on? I don't know if anyone's on today, but I guess we'll just have to drill down on that. That's a great question.
So this isn't going to answer your question, I guess, but I can tell you that my office, as in the coroner's office, if it's intentional, then it's classified as a suicide. I mean, obviously we're talking about cases where the person is deceased at the end of it. And if it's a drug overdose from a recreational drug with no other indicia of intent, it's classified as an accident.
That's interesting. Yeah, and I don't know. If it was an intentional suicide or an intentional overdose, most likely that would be an East Jefferson Fire Rescue call. I mean, that data would end up in their category, most likely, I think. So I'll follow up with them and see.
I just wanted to clarify, because when they come into the ED, I use a national ICD-10 grouper, and the intentional overdoses, we categorize those as suicide attempts or ideation.
They would show mental health on your data, not.
A lot of times, yeah. So we may see some differences.
I would expect that the deputies, when they're putting that in, if it was a suicide attempt with drugs, it would be listed as both. If it was a confirmed suicide attempt, it'd be mental health.
That is what.
Drugs.
That is one of the other things that we've been talking about all along, is how to standardize data and how people categorize it, and when we have duplication and when we don't, and how, all those kind of questions. And so that is another issue I think that we're continuing to work on. And I think John has some next steps on some of that data as well, to try to figure out these kinds of definitional questions as far as how people are categorizing and how standard we can be about whether, if there's co-occurring, do we how we count those and those kinds of things. So we'll hopefully get there. Good questions though. Yes, I think we did that slide. And then
before you go on. I'm sorry, Lisa, can you go back one, Lori? This is great again. I'm just curious if we know how many of the recommendations for inpatient SUD end up in or outpatient SUD treatment.
I don't know that answer. Is I wonder, would Gabby be someone that would know the answer to that? I don't,
John?
I can't tell who's here, so that's a good question.
What was the question?
Oh,
I can restate it. I'm curious from this number, 92% of Jefferson County Jail inmate assessments result in recommendations for inpatient SUD treatment. How many of those actually result in inpatient SUD treatments?
So
I would have to look at the numbers of people that actually went. If they were recommended for inpatient, that's the level of care that they qualify for. We don't put people in outpatient services that qualify for inpatient. However, a lot of the people that do get assessments in jail are then sent to prison, or they're unable to be furloughed to go to treatment. So it really just depends on their individual circumstances and what happens with their case.
Thank you, Gabby. James, were you going to say something?
yeah, I was going to say that anecdotally, many of them will only go to treatment so long as they're being mandated to by the court. And if they get a reduced charge, or if charges end up getting dropped, it's rare to see them still follow through with it, even with the medically assisted treatment. I mean, we've had people who, get approved to get Suboxone. They get it while they're in the jail, and they're approved to go get it locally once they're out of jail, and then once they're out, they don't get it. So it's hit and miss.
I want to push back on that a little bit. I'm sure this won't be a huge surprise. I don't know that we have, I mean, I know that you just qualified that by saying anecdotally, James, and I can respect that. I know of those examples, but I don't think we have enough data at this point to make a generalization like that. Because simply put, we haven't had a system that hasn't criminalized addiction. So it'll be interesting to see whether people do seek out those services, inpatient or otherwise, in the new world of post-Blake Washington. I think that if we were to create a lattice work to allow them to seek out services without fear of prosecution and or being held to account by the fear of prison time, jail time, et cetera, we might have a lot more success.
Since that's where we're going, I hope that you're right, but I do feel very confident when I say that the vast majority of people are there under court order. I don't think that'll change, but I hope it does.
Well, maybe that's why we have such low success rates.
I think on the same, I think if I'm following you right, I think if I'm getting what you're putting down there, I know from the jail with the MAP program, the people that do it in the jail, very few of them continue it after they get out. And I don't think they have any conditions on them at that point. So I don't know if that's getting at the same point or not.
I'll say one more thing on this. I don't have any information about this, but I am curious when we hear OCH about their stigma reduction, whether this is something that might have an interface with that stigma reduction effort.
That'll be coming up. Thanks, Greg. Anybody else on that topic before we go back to Lisa?
So this is the other Lisa, and I think it would be helpful to hear from OPHS about that as well, since they are one of the primary outpatient MOUD providers.
I think we could invite them. They're not actually on the consortium at this point, but we can certainly invite them to get that sort of input. And certainly they can be included in OCH's focus groups.
Thanks, Lori. Let me know if I can help.
Okay, thank you. Anyone else? Okay, I'll turn it back to Lisa.
Looking at the chats while I was waiting. That's an interesting. Someone commented that alcohol is a substance, and so when we or is a drug. It's interesting how different places categorize it differently. Like HRSA calls it alcohol use disorder, opioid use disorder. Some people, so anyway, we could probably standardize how our terminology that way too. So thanks for that comment. That was good. So this is Safe Harbors data, and this was data that they provided for PIM since it was the most recent 6 months. And these are the terms that HRSA had them break it down into, which was the alcohol use disorders. Over 70% were diagnosed with alcohol use disorder, 27% with opioid use, 13% with methamphetamine, and 62% were classified as other SUD. These numbers do include duplication, and with the majority of clients being diagnosed with more than one category of SUD. That's interesting data too. And I think we have a couple more slides, Lori. This was actually data Recovery Cafe gave us last go around, but I just think based on some of the other slides we saw, it's just, I thought it's useful data to look at of the kinds of issues these people are facing as they go into recovery. And it gets back to some of that, the referrals that we just saw from the jail, some of those social determinants of health and the importance of looking at those issues in the community, not just which all of you know, but it's just a really, I thought, a good picture of the kinds of issues that have to be addressed in order to help with recovery. So
I'm curious about housing and financial. I mean, it stands to reason that many of the folks there would have housing issues and also financial issues. But anyway, I'm just curious about that.
Yeah, I'll jump in if that's okay, Lisa. Yes,
yeah.
Patrick.
Yes, please.
This data here, it's tracked when we do intake for new membership, and then we do a quarterly survey of all of our members. And one of the things that we're tracking is recovery issues or recovery challenges. So that's what the member would themselves identify, and that's where this list comes from. So when we say, okay, check the box of what recovery challenge you're facing, they'll do that, or they might write something in. But we also do track housing. What we don't track, though, you had mentioned like socioeconomic status. We're not tracking that data, so that would be an interesting one. But it's not listed on this, but housing and homelessness is something that we do have data for.
Yeah, thank you.
Brian, this is Cherish from OLICAP. I'm also interested in when I flipped through the slides. So I assume sex here is like sex addiction.
That's what is referred to on this, correct? Yeah.
Okay, and then what about people who are registered as sex offenders? Is there any data looking at some of these folks? Because, in Ohio, that was all of those folks landed in these categories over and over again because of their registration status. So is that, I don't have a feel for if you guys have a lot of that here, or if you hear about that, the people that are registered.
As far as the data we're tracking at the cafe, we don't ask about specific crimes or sex register offender status or anything like that.
Okay.
So I don't have that information, sorry.
Okay. Yeah, I was just sort of
It's
curious.
lower
Okay.
here, but there are communities where it's high. It's much more prevalent, let's say like in Port Angeles, than it is here.
Okay.
And this gets back to some of the next steps that we were talking about, that it sounds like we're all on the same page of some things that we need to be looking at further. One is on the data standardization, and all of you raised some good comments today on some more specific things we need to do just as far as terminology and definitions. So that'll be super helpful. John, do you want to take on this slide, or did you?
Yeah. So what we hope to do is meet with some of you individually and see if we can do some work in terms of standardizing data, because there's just some differences in how it's done. And I think it would be more valid and informative to all of us if, as much as we could, we tried to standardize the data. And that may or may not be possible with the data collection methods that you guys are using. So what Lori and I hope to do before the next meeting is to sit down with some of you and just say, hey, here's how Port Townsend PD keeps data. Is it possible for you to keep it in a more similar fashion to what they're doing? Or anyway, so that's some work that we'd like to do. We also found that there was a lot of complexity to the discharge disposition for a lot of the data that we got, and that's particularly for the hospital. And it's part of that is because, you know, when a patient's discharged to home, they may have had a referral to go to mental health, but the discharge disposition that's listed from the emergency department is discharged to home. So we hope to talk with folks at Jefferson Healthcare a little bit more and kind of look at referrals. And then I think when Lori and I started to have that conversation, we realized that we may want to look more completely at referrals in multiple systems like the jail and the hospital and other places. And it's kind of around the question that came up today, and that's when a referral's made, do we have any idea whether that person followed through on the referral, or is it just a referral made and they either didn't follow through or we don't know that information. So that's some other information that we hope to kind of get back to some of you and have some discussion about, you know, was a referral made? Is there a way for us to track whether that was completed, and kind of what's that, you know, what is the outcome related to that? And then we're also, you know, we've been talking a lot today about State versus Blake and kind of what that means. And I think we definitely want to look at what are the impacts in terms of criminal justice, you know, referrals for mental health, behavioral health, and substance use disorder services, and you know, how can we help to fill those gaps? And there's a questionnaire, we're going to talk a little bit about that. And then the last one is the one that we've talked a little bit about, and that's that when Lisa presented this data to us, the kind of the first question that popped into our minds was, well, it would be really, you know, this data covers pretty much exactly the period of COVID. It would be really interesting if we have data that predates that, to look at that and see how those rates compare pre and post COVID. So these are all some things that we're hoping to work on in terms of data between now and the next quarterly report that we do. So you will be probably hearing from some of us in between now and the next time that we get together.
Thank you, John.
Can I make a comment, John?
Yeah.
I think these look great, and I think data standardization is really critical. I mean, it can be interpreted so many different ways. I just, with not being one of the persons who has to generate any data, you know, it's easy for me to make recommendations, but I really appreciated the data that adds up to 100%. It's very difficult for me to look at duplicative data and really understand what it is. So as we try to standardize, that's just my uninformed request.
That's good feedback, Greg. And I think that does get at something that isn't on this slide, but we've definitely recognized as an issue, is that there's often can be duplication in how data is reported, especially when people have co-occurring behaviors. And then do you count those twice or count them once, or how does that work? And so that's something we'll be sensitive to. So thank you for that feedback.
Thank you both, Lisa, for all of your work on this data, for everybody that gave us the data. And it's always just one more step in the process. But I feel like we made a nice little milestone here today in what we're looking at. I'm going to turn the screen over to Melmud, who's going to talk to us a bit about stigma. Now I'm looking for Mel.
Okay, hi everybody, Melmud. I'm a project coordinator with Olympic Community of Health, and OCH received funding to address stigma related to substance use. So I just wanted to give you a skinny look at what we've got and what we're planning, and how we hope you might be involved. So in sum, we were awarded $245,000 to address mental health and well-being of people and families in rural communities. This money also went to ACHs around the state, with less going to King County because they're not as rural. But the money itself was very open-ended. It wanted to advance work to break down stigma around behavioral health issues, and to increase equitable access to behavioral health support services. So just a couple quick definitions, so we're all coming from the same place. Stigma being a negative social attitude attached to a characteristic, person, or group, often leading to unfair judgment and treatment by others. And the substance use disorder, you're probably very familiar with, but it's a disease affecting an individual's brain and actions, and leads to an inability to control the use of drug or medication, whether it's legal or illegal, despite potential harm. For our work with Stigma, we are looking at all the different substances, alcohol, marijuana, down to sedatives, stimulants, and tobacco. So it's an interesting mix because some are legal with prescriptions only, and some are never legal. So our first step is that we want to understand the substance use stigma and its impact. So the way we're approaching that is that we made a contract with a group called Collaborative Consulting. They're public health researchers, and our plan is to engage a range of partners and community members to more fully understand the concerns, the challenges, and approaches to addressing stigma around substance use. So we'll be doing some focus groups, and those are with the, we're targeting behavioral health committees and collaboratives across the Olympic region. Again, that's Kitsap, Jefferson, and Clallam counties. We'll be looking to hear from individuals with lived experience, representation from the 7 tribes within the region, and then 3 open to the public sessions. We'll also be doing some key informant interviews and engagement, and that's, I think, specifically targeting OCH's implementation partners. So that includes behavioral health, primary care, hospitals, and community-based organizations. And finally, we're going to launch a region-wide online survey targeting folks age 16 and older who live, work, or play or study in the Olympic region. So once we've gathered the information, then what? Well, that's based on those findings. OCH, in part, with collaborative consulting, will winnow through, look at the research that's out there, and develop a final set of strategies that'll be based on both the listening and what we know from research about what works and what might be effective. And then this is where it gets a little bit softer because we don't know, but the actions or the activities that come out of it could include training and learning opportunities for providers, decision makers, community at large. And under that, one area we hear about is the opportunity to address 42 CFR Part 2, which, well, the idea maybe that it contributes to stigma because there's this hyper level holding in of information instead of being able to share it to help individuals get the care they need. But we'd also look at communications and marketing materials and partner convenings, as well as possibly telehealth support to ensure clients can connect with providers as Healthcare Authority begins to wind down their efforts in that area. So the timeline. In February and March, we started working with Collaborative Consulting, and they did the background research and planning. Starting this month and through June, we will be conducting community engagement and focus groups. So that's the survey as well. In June and July, they'll analyze that data as well as look at research models for addressing stigma. August, September, share findings and plan next steps. So that'll have the community engagement part. And then finally on to implementation. And with implementation, again, the funding was flexible. And it said that the money did not need to be spent by 2021. We could have through 2022. So the timeline for that is, again, a little bit unclear, and it will depend on what we hear and learn from our listening and engagement. So with that, you know, looking at this idea of tackling health issues no single sector or tribe can tackle alone, that's part of why I really wanted to reach out to this group. You do a fabulous job of connecting with each other, and you have such a diversity of voices that sit on this consortium. So it's one place that we would love to be able to connect with for a focus group. And Lori, do you want me to continue or do you want to continue?
Go ahead.
Okay, so my ask is to this group, we would really like you to be one of our focus group. You would be your own group. And we could come to your next meeting on May 19th, and we would ask for about 45 minutes of time to do an engaged discussion on stigma and perspective and the different drugs, and really being able to hear from you in Jefferson County.
Sure.
So we're happy to receive folks. If my instinct is to say yes, but I wanted to make sure folks in this group are on board with the idea.
Mm-hmm.
All right.
Yeah.
Mel, I really appreciate you coming and giving us an overview. It was very exciting when OCH got that funding, and we're excited to be able to give input to whatever the next stage is going to look like, and excited that we'll know in August kind of what sort of things have been learned. So I know it's a big undertaking, and we're grateful you're in charge of it.
Wonderful. I'm a helper bee, but I'm glad to be helping on this. And thank you all so much. I think the work you do is really amazing and inspiring.
And Mel, before you leave, be sure to check the chat. I just sent you an idea that you might want to pursue.
I cut and pasted. What I need now is your email.
Oh, sure.
And Mel, I sent you a chat as well.
Great. Thank you, everybody. I love your ideas and look forward to working with them.
Great. Thank you. Mel, okay, so you have let go of the screen. So now I'm going to share, and then John is going to talk a little bit about the survey that we did over the past few weeks. Can you guys see the presentation now? Okay.
Mm-hmm.
So Lori had sent out a SurveyMonkey survey to you folks about State versus Blake, and we were trying to get some feedback from you guys. So there were 3 questions on the survey, and what I tried to do was kind of scan all of the responses. I think Lori sent out a document that has all the responses, so totally encourage you to take a look at that and read the detail. But what I tried to do is scan those to see if there were any kind of common themes that emerged from the survey that we sent out. So the first question was about how people perceive that State versus Blake would impact them at an individual or organizational level. And this is the one where I felt like there was a pretty broad range. At least one of the respondents said no impact. Another respondent said it will change everything. So broad range of responses. But if there was a common theme, and this was actually a number of the respondents said that they weren't really sure yet how it was really going to impact us. And so I think that for that first question, that's probably the common theme, is that the jury's still out, still a lot of information to gather, and people are kind of anxiously awaiting to see how this will actually play out in reality. The second question was around how you and your organization, what questions are you guys asking yourselves around State versus Blake? And the common theme here was that people want to find a way to continue to provide resources and recognize that the potential impacts of State versus Blake may impact that, but they may have to go a further step to be able to provide those services and find ways to communicate to potential clients, how they can provide those services. So I was impressed with the motivation and interest that people showed in being able to continue to provide services to people, even though they likely won't be mandated as much in the future. And then I think the third question.
Did I say third? Sorry.
Yeah, thanks, Lori. The third question was to brainstorm around the State versus Blake through the BHC lens. And, but here the common theme was respondents felt like we need to get a different set of incentives to get people into treatment, and that we're going to need to up our game in terms of better outreach and avenues for people to get treatment. And Nate, I think that was some of what you were talking about as well. And I think it'll be really interesting, to see how this plays out and to see how people react in an environment where they're, it's less punitive and more, more following kind of a traditional treatment model. So I think those are the themes that I saw, and I'm just curious if people want to comment on those or have thoughts in addition to what I noticed in my notes.
Well, I think one thing that we should probably clear up is that even if this decision stands and the legislature doesn't do anything with it, I don't see that changing the stigma at all. Not one bit. I mean, there are plenty of things that are legal, have been legal for years, if not ever, that are still stigmatized behaviors within our culture. So I don't see that flipping overnight.
James, I was wondering, do we know more about our, is this law going to become finalized? Is there a process? Is it going to be 12 months before we know it?
So the state submitted a motion for reconsideration. This is actually out of Spokane County. They filed a brief. The Supreme Court asked for a responsive briefing from Mr. Blake, which is an interesting sign because they don't always do that on a motion for reconsideration. Meanwhile, the legislature is, also taking up, this and taking a look at it and seeing if they want to change anything. I don't expect the legislature to do much. They might recriminalize it for juveniles, but I don't know. So all sorts of things could potentially happen.
So it's up in the air, and we really don't know for how long it's up in the air.
But yeah, it won't be a year. I mean, I would expect by June, and the legislature session is going to be over within a month. Supreme Court will probably have a decision either by May or June.
John, did you want to say anything more to this slide, or shall I?
I mean, I think people can kind of glance through it, but basically we want to, just keep track of what's going on with this and make sure that, we're in tune with any potential changes that are going on relative to that. And I think it'll continue to be on our agenda for upcoming meetings, just to make sure that we are adjusting to these changes as quickly as possible.
One of the things that
go ahead, Lori. I bet you were going to say the same thing, but go ahead.
Well, I don't know. One of the things that I'm happy about is no matter what we do on this, any other new innovative ways we come up with for outreach, they're still going to serve us whichever way the decision goes, or the landscape ends up changing or not changing at the end of the day. So I don't think that our efforts are ill invested on this.
Can I mention something, Lori?
Yes.
So I think that we have a really good opportunity as I like to call us the other BHC, because I'm involved in the Behavioral Health Court, which is also BHC. But as a consortium and as a kind of brain trust for Jefferson County, if you will, there are things that have already been done by organizations in this county that are like really progressive when it comes to supporting people struggling with addiction and in the behavioral health community. And often we know there's a lot of overlap there. One of them that's been wildly successful is the PT/PD attached navigator, Judd Hayes, who's here. I think I saw you, Judd.
Yes.
And I think the fact that JCSO now has a navigator attached as well is a really positive development. And I just think that expanding on the things that are working, I can tell you that, from our perspective, the caseload of people struggling with psychosis and also really advanced addiction issues within the city of Port Townsend, and the arrests have gone down significantly since Judd's been on the job. And I don't think that's a coincidence. And so, and meanwhile, it's not like those problems are going away. It's just that at their inception, they're being dealt with by a much more appropriate type of person, and that is somebody who's specially trained in those issues. And so I guess what I'm trying to say is, I think we have some evidence that we can make a big difference by addressing these issues outside of the criminal legal system. And I think we should expand on those programs, and we should encourage those who are here, who have that power, to use that as momentum to push forward. I'm not as pessimistic as some others here about a post-Blake world. I think we're being handed a huge opportunity. And, we've known for a really long time that the war on drugs is not working. It's just made things worse for our communities and for individuals and families, a whole lot. And that this is a medical issue. And so we need to treat it that way. And here we are, a lot of powerful people in this community. I think we can do it.
Thank you, Nat. Okay, more discussion on that I'm sure will happen in the next meetings. I know we are 2 minutes over right now. I'm just gonna quickly show you that there are some other things you can look at in your packet, some funding that has come out from OCH, their COVID funding, connection to some articles and OCH's annual report that might be of interest. Lots of project summaries of things that we're doing. Feel free to call me if you're interested in any one of these or multiple of them. And our next meeting is on Thursday, May 13th at 3 p.m. And thank you so much. Some of you are going to be following us onto the next Zoom link, which is for the working age group. So we'll see you over in that room. And thanks to everybody else. Have a great afternoon.
Thank you.
Everyone.
Thanks, everyone.
Bye-bye.